Calvin Lee is going to give us a talk about genomics screening. I am very interested in learning more about genomics screening. And so please go ahead and take it away, Calvin.
All right, thanks for the introduction, John. So I'm Calvin. I'm one of the medicine R2s. I'm going to talk to you guys a little bit today about sort of some guideline updates on genomic screening. Personally, it's a pretty interesting topic on my end, and there's been a lot of developments over the last couple of years in this field as well. And I imagine so as we progress through residency and then ultimately into our full careers, that there'll be more concrete guidelines on this of these nature. So brief overview of my learning objectives for today. So we'll start by going over some basic discussion methodologies behind genetic testing. We'll go over some terminology that you might encounter when interpreting the results of these tests. We'll look over some specific clinical scenarios where testing can be ordered and can alter patient management. And then we'll round out the talk by looking at some ethical, legal, and some practical issues over genetic screening that might come up when you counsel your patients about these tests. So we'll start with some discussion of basic principles, and feel free to interrupt me anytime during this talk if you have any questions or comments. So I'll start with a brief overview of the history. A lot of the advancements in genetic technology have obviously come over the last couple of decades with the advent of next-gen sequencing in the late 2000s. A lot of this research kind of goes back to the early 70s and mid 70s with like standard sequencing and then PCR in the 80s. The Human Genome Project, as most people know, kind of began in the 90s and concluded in the early 2000s. And so as we advanced over time, the amount of genetic data that has been available to clinicians has increased pretty exponentially. At the same time, because of all this data, we spend a lot more time trying to analyze data rather than probing it for specific questions. There are a couple of targeted methods for ordering genetic tests, kind of going from very targeted testing to sort of wide panels. So the first thing that we often talk about is very targeted genetic testing. So usually ordered in cases where there's either a single gene that's the culprit behind a disease, like Huntington's disease. We see this a lot on the medicine side for we evoke something like factor V Leiden, for example, sickle cell, hereditary hemochromatosis, for example. A lot of hereditary cancers are due to mutations in one or a few genes, and oftentimes we could directly test for those. Turning the second panel is sort of what is most commonly available on the commercial side of things. So gene panels, which offer tens to a few dozen genes that are done by next-gen sequencing. These are often used for a lot of the hereditary cancer syndromes that we'll talk about. These are used for risk stratifying and finding targets for cancer therapies like you'll see on the HemOnc service of the UW. Similarly, HLA typing, drug metabolism panels are sort of the second group. And then finally, less well-researched is sort of this whole exome sequencing or whole genome sequencing, which looks at all sort of the genes that are either expressed or the entire genome itself. There are some studies in other countries like the UK that look at to see the utility of this, but unfortunately at this point in time in the US, not a lot of guidance regarding these two sorts of sequencing technologies, and there's variance in whether insurance companies will cover that sort of testing. So we'll go over some basic terminology. When you get results back from genetic testing, there's sort of 5 broad categories that a variant can be classified as. The first is pathogenic, where this variant is known to cause disease or is strongly associated with the disease process. There are variants that are likely pathogenic, so based on studies, greater than 90% confidence that it's a pathogenic variant. Kind of more difficult for us as clinicians is sort of the VUS or variant of uncertain significance, where there's not a lot of data or conflicting data about whether or not this variant can cause disease. And then likewise, there's the sort of the mirror categories of likely benign and then benign. So briefly, we'll talk about where sort of all this data sort of comes from. So a lot of the clinical societies that classify these variants use established clinical databases. and they can sort of directly see whether a variant has been associated with either a known disease process or found overwhelmingly in like control patients that do not have the disease. When that data is not conclusive, they move on to molecular basis of testing. So is the variant a known loss of function, like a null or a frame shift, or does it cause issues in a known domain of the protein? And then there's assays that can either use computational algorithms or functional assays to directly test whether a variant is pathogenic or not. So now that we've talked a little about some terminology, I'll move on to some cases to highlight some utility of genetic testing in medicine. And a lot of my talk comes from this sort of 2023 NIH Precision Medicine Program. NIH kind of defines 4 broad domains in where genetic testing can be used in medicine to sort of guide clinical decision making. The first is sort of this precision oncology, which relates a lot to cancer screening and hereditary cancer syndromes. Cancer immunotherapy is a second category that relates to whether tumors have or other cancers have known targets, molecular targets for therapies. A growing field is pharmacogenomics, which looks at gene-drug interactions and then found there's rare diseases, which relates more to newborn screening and prenatal counseling. So for this talk, I'll focus more on sort of these 2 categories. So cancer screening and then some pharmacogenomics, which is more in line with a general medicine talk. So we'll start with a case. So in this case 1, you see a healthy 21-year-old woman in clinic. She's here to establish care. Sort of over the course of your clinic visit, you go over family history, and she begins to express concern that her mom was recently diagnosed with breast cancer, and she wonders if she herself is at risk at this point. So getting more history from her, we don't usually do this a lot in internal medicine, but this is sort of, if a patient is seen by genetics or oncology, you'll often see a pedigree like this serve in the chart as a way of expressing family history. And so I'll go over some brief terminology about how to interpret these sorts of things. So in a pedigree, there's always an arrow that refers to the proband or our patient. And then, circles in a pedigree represent females, and then males represented by squares. And then there's usually a legend of some kind that goes over what diseases are in the family and notation about the age of diagnosis. So for our patient, we see that she has a healthy brother. So on the paternal side, there's no known cancer history at this point. But on the maternal side, you see that her mom was diagnosed with breast cancer at age 42. Similarly, she has a maternal grandmother that was diagnosed with ovarian cancer at 49, and some maternal aunts and cousins that also have ovarian and breast cancer diagnoses. And when you hear, from some of the societies, they'll define 2 terms. So first degree relative is in relation to the patient, their parents, their siblings, or their children. And then you'll hear second degree relatives as sort of the relatives beyond that. So, overall, looking at this pedigree and sort of looking at it textually in the chart, this is a pretty concerning family history for an inherited cancer syndrome. So the first thing we'll talk about is hereditary breast and ovarian cancers. There's been a lot of new updated guidelines sort of in this regard, and the guidelines kind of vary by the professional society that dictates the guidelines. So in 2019, the USPSTF put out a grade B recommendation. So BRCA-related cancer screening should be offered to women with a suspicious personal or family history, or who you use a risk assessment tool to grade their risk and their elevated risk. The National Comprehensive Cancer Network, which is a consortium of different cancer treatment centers, of which the UW is a member, recommends targeted testing for individuals who meet a specific set of criteria. Some societies, like the American Society of Breast Surgeons, are more lax with their recommendations. So they actually recommend targeted testing for all women with a history of breast cancer, in addition to those that meet established criteria. And I think a lot of the difference in this recommendation is, as we'll see, one of the criteria is the age of diagnosis. And unfortunately, we're seeing breast cancer be diagnosed like in younger individuals. So I think that's what's sort of driving a lot of their changes and recommendations. There are a lot of tools that can be used, and they're all sort of available in a table or textual format online or up to date or MD-Calc, for example. And all these tools I listed above are validated tools independently, and they're all included in the USPS TF recommendation. So Ontario Family History Tool, Tyrer-Cruikshank, BRCA Pro, Manchester scoring system. And we'll go over sort of how this is used sort of in practice. So on the right side of the screen here is sort of a screenshot of the online version, the Ontario Family History Tool, and it basically looks at a patient's family history and assigns points based on the presence of cancers in the family and how close of a relation that relative is to the patient. And a lot of the tools are threshold based. So for this tool, you score 10 points or more, you qualify for a genetic referral or testing based on elevated risk. So for our patient, for example, we use it by relative. So she had a mother with breast cancer, so she gets 4 points based on that. And she gets another 2 points based on the age of diagnosis. And then you will repeat this for all the other family members who had a history of cancer in the family. So some tools rely entirely only on the family history. Other tools like the Tyrer-Cruikshank incorporate patient factors, so age of menopause, use of hormone replacement therapy, breast biopsy results if available, to more accurately represent a patient's cancer risk. And obviously, because all these tools actually heavily rely on family history, patients who do not know or do not have access to their family history are at disadvantage in terms of screening. We'll go over testing criteria for breast cancer syndromes from the NCCN. So they divide these folks into two broad categories. So folks with a personal history of breast cancer, and then folks with only a family history of breast cancer. So for individuals with a personal history of breast cancer, you should offer testing for all folks who are diagnosed with an age less than 50. Similarly, for any age of diagnosis, if you're using your genetic testing to guide systemic treatment decisions, often for poorly controlled metastatic cancers where you're trying to find genetic targets. Similarly, for any individual with multiple primary breast cancers, the idea being that sporadic breast cancers are relatively uncommon. So to have two sporadic cancers in the same individual implies that there's inherited genetic risk. Similarly, for triple negative, so estrogen, progesterone, HER2 receptor negative breast cancer, there's a strong association between this and hereditary syndromes. And similarly, these are very aggressive cancers that may benefit from increased surveillance. And then finally, any breast cancer in a male, the overall risk of breast cancer in a male is 0.1% lifetime. So the fact that it's found is a really rare occurrence. And then breast cancer in a patient with Ashkenazi Jewish ancestry. And then similarly, if an individual only has a family history, they qualify if they have a first or second degree relative who meets any of the above criteria, or if they score greater than 5% risk based on a validated tool. So for this patient, we think that she qualifies for breast cancer screening, and the next question is sort of what genes do we test? So it's guideline specific. NCCN and most insurance companies will cover the above genes, the BRCA1 and 2, which are sort of the genes are most known for association between this and hereditary syndromes. You'll also notice that there are some other tumor suppressors like P53 up there. And oftentimes insurance companies will cover entire panels that include these and some more genes. And then finally, there's a question of what to do when a patient returns with a positive result. So, at the UW, we're lucky enough to have a genetic counseling and medical genetic service. And oftentimes they're helpful for both coordinating all the surveillance and multidisciplinary care these patients need, in addition to involving social work, ethics, and all the other supportive teams as well. And the reason why the USPSTF is recommending sort of BRCA screening more as a strong recommendation is that there's benefit of increased surveillance, and surgical risk reduction. So um, individuals who have a positive BRCA1 or 2 variant have a pretty elevated risk of breast cancer, so lifetime risk of 60%. And breast cancer can occur relatively young in these patients. I think the youngest reported case in the literature is age 15, actually. So for individuals who test BRCA1 and 2 positive, they recommend annual breast cancer screening either with an MRI, mammogram, or both starting at age 25. And as patients get older, this could be more of an individualized decision based on their overall risk and family history. Similarly, most professional societies recommend discussion or risk reducing mastectomy. So there's high evidence for this in BRCA1 and 2, as well as some other tumor suppressor mutations. And overall, bilateral mastectomy reduces breast cancer risk by about 90% in these folks. And similarly, there's a similar risk reduction for bilateral subpingo-oophorectomies, and there's different ages of recommendation for whether a patient is BRCA1 positive or BRCA2 positive. Additionally, we tend to screen males in these families as well because there are increased cancer risk in men who test positive, especially for BRCA2. Lifetime risk of prostate cancer in these folks is about 25 to 60% based on age. These individuals have about 10% risk lifetime of breast cancer. So there's recommendations for annual screening mammograms, as well as prostate cancer screening starting at age 50 and 40, respectively. So that's a brief overview of sort of hereditary breast cancer syndromes. Before I move on to talk about other cases, were there any questions at this point or any places where you want some clarification?
Calvin, can I ask you a question?
Sure.
My question is if they have the first degree relative, but they're like, oh, my relative was tested and negative. Do you still recommend testing for the family members, or do you just recommend testing for if they can prove that the family members who had the disease were already tested and negative? Then do you still recommend that just the family history they get tested?
Yeah, I think that's sort of a patient-centered decision. And, you can test the patient just to make sure that they're truly negative, or, sometimes I've seen in their medical genetics that they just say, hey, the relative is negative, so therefore the risk of a new variant is very low, so we can decline testing at this point.
Great, thank you.
All right, so I'll move on to a second case. So case 2, 25-year-old gentleman, he presents to clinic with 2 years of recurrent and intermittent hematochezia, abdominal pain. For the past 6 months, he's also noticed some intermittent weight loss. He asked about family history. It's notable for colon cancer, both in the patient's father and paternal grandmother, both diagnosed in their 40s. And similarly, the patient has 2 healthy siblings. Really, what this case is going at, there's new or evolving guidelines about hereditary colon cancer testing. So USPSTF does not have any current recommendations at this point. Other societies like NCCN recommend limited testing for Lynch syndrome and hereditary polyposis syndromes. So I'll briefly give a review of what these 2 things are. So Lynch syndrome is the most common hereditary colon cancer syndrome. It accounts for about 3 to 4% of all colorectal cancers. Patients with Lynch syndrome have an 80% lifetime risk of colon cancer. They're also at risk for other cancers like endometrial cancer, about 60% lifetime risk there. Lynch syndrome is what's called non-polyposis type syndrome. So patients actually don't develop a ton of polyps, less than 10 in their lifetime. And the pathophys is that it's caused by mutations in DNA mismatch repair genes. In contrast, familial adenomatous polyposis, or FAP, is much more rare. It only accounts for about 1% of colon cancer syndromes. In contrast, though, patients with this disease develop hundreds to thousands of polyps. And sort of on the image on the right, so an endoscopy, sort of a young age for a patient showing early polyps, and then later as these polyps mature. Polyp formation begins in childhood, so about half of folks get polyps at age 15, and then 95% of folks have polyps by age 35. And all the polyps will invariably become colon cancer if not managed within with a lag time about 10 years. And it's caused by mutations in the APC gene, which is the tumor suppressor. So who do we test for hereditary colon cancer syndrome? So if there's a known history in the family of a pathologic variant, other members in the family should be tested. Any individual with a personal history of more than 10 polyps found on endoscopy should be tested. And there's a much stronger recommendation that you find more than 20 adenomas over the course of a lifetime. Age of diagnosis less than 50, which is becoming much more common in folks nowadays, especially as we're screening for colon cancer at an earlier age. And then finally, any age of diagnosis if the pathology of the tumor itself shows mismatch repair deficiency, suggesting Lynch syndrome. And once again, positive results can influence patient care by increasing screening. So for familial adenomatous polyposis, for example, your absolute risk of colon cancer is 100% without treatment. If your APC gene is mutated, they recommend annual colonoscopy starting at a very young age, so 10 to 15. For the other syndromes, it's often gene dependent, and at this point, oftentimes it's a multidisciplinary meeting with medical genetics, GI, other services, but typically it's screening every 1 to 2 years, starting in the mid-20s. And as I said before, patients with Lynch syndrome are elevated risk of other cancers like endometrial, ovarian, renal, pancreatic. So they can be offered further counseling based on what variant results. And sort of as a note, a lot of the times patients with these disorders are very medicalized. So a lot of the screening carries a significant burden on both the patients and their families. So a lot of the times these decisions are also made in a patient-centered way with sort of good counseling. This is sort of the last hereditary cancer syndrome I'll talk about. So before moving on, I'll leave the room for any questions before we move on to a different topic. All right, if not, then we'll talk about pharmacogenomics.
Calvin, I think there's a question in the chat from Rini. If the patient has VUS and later is found to be characterized as a positive result, what system is in place to update the patient about the result? Is this on the PCP or does the lab testing company handle this? Sorry, I don't know what is VUS, Rini?
Yeah, so VUS is a variant of undetermined significance. So data doesn't show either this is known to be benign or malignant. Unfortunately, I was looking this up actually because I had this question myself, and unfortunately, labs do not routinely go through and reclassify patients' results. So unfortunately, this time there's not a lot. That's a risk that we counsel patients on. So there's not a lot you can do after you get your initial result. Labs not routinely retest patients or routinely go through old results. So it's really dependent on where the institution that they get the results at. And it's usually on the testing lab itself. So pharmacogenomics, growing field of interest. So starting around 2019, about 300 meds have an FDA label that recommend some form of genetic testing or prior to either starting the med or as guidance for dose adjustments. Utah Medicine actually did a retrospective study in the early 2010s that showed that only about 1.5% of med orders with either recommended or required testing actually had that testing ordered in the chart. And currently, the FDA recognizes 3 broad categories of gene-drug interactions. So the first category is interactions where the data strongly support a therapeutic management recommendation. And there's about 50 meds that belong in this category. The second is sort of less strong, but interactions where there's a potential impact on patient safety or medication response. And then finally, a lot of the data at this point showed that there's only an impact on sort of drug levels, pharmacokinetics without any downstream effect on patient outcomes. So this is pulled from the FDA website, to sort of the table documenting the current medications that show a strong therapeutic management recommendation. So about 50 drugs on this list. List the drug, list the gene that is implicated, It lists the alleles that are implicated as well, and then a brief descriptor of the interaction and any therapeutic recommendations. And there's a lot of common meds that are in this section. So a lot of antipsychotics. So you'll know the aripiprazole is on there, clozapine's on there, anti-epileptics like phenytoin. There's some antidepressants, so venlafaxine is an SNRI, and then SSRIs like citalopram. Antiplatelet medicines like clopidogrel, and then finally anticoagulation meds like warfarin are also listed on there. So we'll go over cases for two meds that I think are important and commonly encountered as a general internist side. So the first case is a case that I saw Harborview. So you're treating a 41-year-old gentleman with diagnosis of HIV on the inpatient service for unrelated cellulitis. Unfortunately, the patient is unhoused. He's been off his ART regimen for a while. CD4 count is 110 on admission. You know, the patient's nearing discharge. They were started on ART, but you know, as they approach discharge, you know, a pretty severe documented allergy to Bactrim or trimethoprim sulfamethoxazole. And so what we're getting at here is initiation of dapsone for PCP prophylaxis and G6PD deficiency. So G6PD is the most commonly encountered gene-drug interaction. It's associated with a risk of hemolytic anemia from oxidative stress. And G6PD is the enzyme that forms the NADPH that cells need to sort of reduce these reactive oxygen species. And the highest risk medication that's commonly encountered is dapsone, but as you'll note, there are a few other medications like methylene blue, primaquine, and some of the uric acid lowering medications like respiricase have been implicated as well. And obviously, there's strong recommendations to either avoid these drugs if the patient is G6PD deficient. And I feel like this is a common thing that, you know, we often miss before, unless, you know, ID or something or some other service recommends the testing. So ordering the testing up front can help save some time for all of us. And then finally, I have one more case. So case 4 is an interesting case that I found sort of in literature review. So 60-year-old gentleman, he came in with some cardiac risk factors like type 2 diabetes, hypertension. He underwent coronary angio for exertional angina. During the procedure, he had 90% RCA stenosis, so he underwent 2 drug-eluting stents. He was started on DAP, so aspirin and clopidogrel, sent home. 4 months later, he came back. He had some persistent chest pain. They found that he had an in-stent thrombosis, and he was restented. Once again, discharged home, but 2 months later had recurrence of in-stent thrombosis. And the providers here during this third hospitalization did a platelet function assay, which showed that he didn't have sufficient platelet inhibition despite being on DAPT. So this is sort of getting at clopidogrel metabolism, which is one of the medications that has been strongly associated with gene-drug interaction. So clopidogrel is not an active medication by itself, and undergoes extensive liver metabolism to an active metabolite that then binds the platelets. These are done by liver cytochrome. So the rate limiting step in most folks is this sort of cytochrome 2C19 or CYP2C19. And there's been a strong association between East Asian ancestry and loss of function alleles in these folks. So the patient in the vignette was of self-reported Korean descent. And this relates to what is known in the literature as clopidogrel resistance. So as I said, you know, clopidogrel is converted to active metabolite by the liver. And it's been studied in sort of the post-PCI population that there's been association between these loss of function genotypes and poor clinical outcomes. So this is some data from a large multi-center study. The patients here underwent PCI either for chronic angina or ACS. And they were genotyped and then they were randomized to either clopidogrel or an alternative P2Y12 inhibitor like prasugrel or ticagrelor. And this study looked at major cardiac adverse events, so all-cause mortality, MI, strokes, in-stent thromboses up to 1 year after the initial PCI. So panel A is all patients, panel B is patients who underwent PCI for ACS, and panel C is patients who underwent PCI for non-ACS, so like stable angina or other indications. And they found that in patients who had loss of function alleles at CYP2C19, that there was an increased incidence of cardiac adverse events up to 1 year after PCI. So the hazard ratio, and I think the study was 1.7. But this was not seen in patients who had loss of function alleles and were treated with an alternative P2Y12 inhibitor like prasugrel. So this was published in 2022, and there's not yet a unifying recommendation from the ACC or AHA about routinely testing patients for clopidogrel metabolism after PCI. But a lot of clinical pharmacists, consortiums, actually recommend this, and it's currently being actively investigated. So I'll finish out the talk by talking about some ethical and sort of legal considerations with regards to genetic testing. But before I get there, I just want to leave some room for any other questions at this point.
Oh, hi, Calvin. Yes, I had a question on the dapsone and the G6PD deficiency. Is that like a standard, anyone that you would start on dapsone, you would test them for that deficiency?
Yeah, so if you're starting a patient on dapsone, you should test for it. Sometimes the testing is already documented in the chart. You'll need to order new testing, obviously, but they should have a documented test prior to initiation of dapsone.
Okay, great, thanks.
All right, so we'll move on to some ethical and legal considerations regarding testing. The first one is sort of disclosure results. And obviously, you know, a lot of the realm of genetic screening is sort of familial risk. So patients are often interested in getting genetic testing to see if they're themselves at risk or if other family members are at risk of a genetic syndrome. And oftentimes patients want to disclose these information to their family. However, there are cases where, you know, patients get the results back, but and as a result, they do not want to share because it can cause privacy issues in terms of their own medical results. So in these situations, you know, as physicians, do we have a legal duty to warn family members about positive genetic risk? And you know, there's some case studies in this area. I don't profess myself as sort of a legal scholar in any means, but so looking through, it's still quite a legal gray area. Most case law would suggest that physicians do have a legal duty to warn family members of genetic risk. And there's two cases in this regard. So the first is sort of this Pate versus Threlkeld test case. And this basically was a case about the physician's duty to warn. And it stayed in the court's decision in this case so that physicians do have a duty to warn a patient's relatives, including children, about implications of testing. But the court decided that, you know, counseling the patient directly about these risks was sufficient to meet that requirement. So telling the patient that both they and their family members are elevated genetic risk was sufficient in this case. However, there was some sort of discourse with sort of the second case, Safer versus Pack. In this case, was a patient had a family history of familial adenomatous polyposis. The physician had treated the patient's father for this disease, but did not inform the patient, and she developed aggressive colon cancer at a later age. And in this case, the court noted that a physician does have a duty to warn family members about inherited genetic risk, but that warning the patient directly was not sufficient. And that physicians need to have a responsibility to do a reasonable effort to warn family members. And the crux here was that they argued that genetic information is not necessarily personal data only, so it's not patient data only, but it's actually familial data that's inherited. So there's a duty for physicians to sort of make a reasonable effort to warn family members. And talked to some folks at the medical genetics clinic here, and there's some guidance from the American Society of Human Genetics to sort of what to do when there's sort of this discourse between the patient's autonomy as well as our duty for beneficence and justice to warn others. So some professional societies say that it is reasonable for physicians to sort of forego patient confidentiality and make attempts to warn if all the following are met. So attempts to encourage disclosure from the patient have failed. The genetic harm itself is serious and foreseeable. The individuals who are at risk are readily identifiable. And finally, the disease process is both preventable, treatable, or would benefit from early monitoring. And in speaking with some folks that work in the genetics clinic, this is a really tough situation to be in. And oftentimes, these physicians don't go it alone. They have to bring in medical ethics, social work, and other folks to sort of help out in this regard. The second thing that patients often ask about is the idea of genetic discrimination. So that's the idea of using genetic information, genetic testing to sort of make health insurance decisions, employment decisions. And there's two major federal laws that protect patients against the use of their information against them. So the first is GINA, or the Genetic Information and Non-Discrimination Act. This was passed in 2008. This squarely prevents health insurance carriers from using or requesting genetic data to make decisions about coverage, premiums, or eligibility. There are a lot of limitations to this law. So it only applies to health insurance, does not apply to life insurance, long-term care, disability insurances. And most importantly, it does not apply to individuals who receive their healthcare or insurance through either the military or federal government. So our VA population, for example. The Affordable Care Act and Patient Protection Act of 2012, aka Obamacare, tried to recognize some of the holes in this by calling genetic variants as pre-existing conditions that would prevent people from losing their health insurance or facing increased premiums. And different states have additional protections on top of this. Unfortunately, Washington State does not have any additional protections. Some states like California and Oregon have state laws in place that regulate sort of the use of genetic information in the workplace. A lot of states are now beginning to put more regulation on whether third-party companies like these direct-to-consumer companies like 23andMe, how they use their genetic information. So currently, it's a pretty unregulated field. But there are new laws in California, for example, that require these companies to get your explicit permission if they're using the data for anything besides their ancestry testing. So selling the data, using it for marketing purposes, selling it to third-party companies. But unfortunately, Washington State does not have any of those laws in place as of yet. And then finally, is the discussion of cost. So a lot of patients are concerned about the cost of these testing, and fortunately, Washington State Medicaid and Medicare often gives pretty good coverage, although prior authorization is often needed in these cases. So Washington State Medicaid will cover BRCA screening for patients that meet NCCN guidelines. They'll also cover screening for cystic fibrosis, Lynch syndrome. They'll cover gene panels for certain types of cancer to guide therapies. And then finally, Washington State Medicaid covers all pharmacogenetic testing for any medication with an FDA recommended or required label. And finally, Medicare coverage will cover BRCA screening and Lynch syndrome. And then in terms of private insurance, most private insurance companies that I briefly looked through kind of share similar to the Medicare coverage. So they'll cover basic screening for BRCA and Lynch. In addition to some other testing that is insurance dependent. So in summary, I just want to give a couple of key takeaway points from my talk. So the main point is hereditary breast and ovarian cancer syndromes are now routinely recommended to test for individuals with either a suspicious personal or family history. There's been an increased role of testing for other hereditary cancers like colon cancer. There are a lot of new guidelines for screening of drug gene interactions. I put a link to a clinical pharmacist sort of organization that publishes some of these guidelines. There's about 26 current guidelines that are published. And then the last point is that there's increased impetus from insurance companies to cover these things for our patients. And that's sort of it. So give some thanks to Marianne Dubar-Galt, who helped me put together this talk. She's one of the medical geneticists at Fred Hutch, and then some other folks in the med-ed pathway, Eric Lamont and Matt Holmberg, who helped review this talk as well. And I'll leave the floor for any questions that y'all might have.
That was a great talk, Calvin. John had to step off, but he had a question that he asked me to ask if there was time, which I think there is. Our next session is at 10:45, so those who need to take a break, feel free to do so. His question was the direct-to-consumer companies that are doing genetic testing, and specifically the ethical issues that you mentioned, and how, if there's any, anything, this may be kind of beyond scope, but if you know anything about how that's all played out.
Yeah, so unfortunately, kind of an unregulated field. No real federal regulations in that regard. As I said, some states like California have passed some legislation to try to rein in a lot of the data that is collected by these insurance companies. But oftentimes people worry about whether this can be used, shared with third parties, used for marketing. And a lot of states are trying to pass legislation to make it so that these companies require your express permission every time this data is used outside of strictly genetic testing. But unfortunately, it's still quite an unregulated field.
So do you think there's kind of a risk that, for example, if a family member is not informed, some of these companies could be on the hook or something like that? Or we can't say because there's very little regulation?
Yeah, we can't say, and oftentimes these companies don't directly sequence genes. They use SNPs and other things that are not as well validated. So no society really recommends these direct-to-consumer testing as diagnostic or screening tests. In the context of answering ancestry questions, that's a different scope, obviously. But for medical decision making, oftentimes these are not validated. Certainly, some companies offer drug metabolism panels or direct gene testing that you sometimes see in clinic when patients bring it in. And these are often more validated and can be used. And usually these labs that do these direct sequencing or other things have more protections in place for patient data privacy.
Perfect, thank you. I also so I think we have time for about a 10-minute break, or 7 minutes now. Thank you so much, Calvin, for that great talk.